I'll be very quickly coming to the main point of discussion, contouring in breast cancer, the practical tips and tricks. I made this presentation targeting the practitioners who are mainly early in their phase of practice or mid-level in their practice. However, this might be helpful for everyone, and I will not be going to any practical discussion on indication, contraindication, when to do, how to do. So I'll be very much limited to my discussion on how to contour, what to contour that way. So I have divided the different scenarios like whole breast radiation, sequential boost, simultaneous boost, post-mastectomy radiation, external beam APBI, and nodal radiation. So there are a couple of basic things we should always follow while we contour, no matter whether it is breast or head, neck or anything. These basic principles should always be there. The first thing which I always like to mention, that no amount of optimization can compensate for a bad contouring. So if you are contouring your target and we are wrong, then you are actually wrong everywhere. That becomes a systematic error in the entire system. And radiation, once given, it's given forever. You cannot take that radiation away from the body. You cannot remove the DNA damage caused by the radiation. So your contouring before starting the treatment should always be absolutely fine. And every effort should be made that the contouring, the planning, and inter-dose distribution is actually acceptable. The target which we are mainly concerned about when we contour also depends on the organs at risk, and that's why we should never forget that contouring OARs are equally important, or in some scenarios probably it is more important than actually contouring the GTV, CTV, or the PTV. Because one more thing, whatever you are contouring, the software does not know. It does not know what is heart, what is lung, what is tumor. So whatever you are showing the software or the computer as tumor or organs, the computer does not understand. So you have to always make sure that there is no error, including the laterality. Many a times it's a very common mistake that left-right is actually wrong, or some structure is given a different name. And physicists do not understand whether the contouring is right or wrong, because they go by the nomenclature. So if you mark heart as breast, the system will always recognize heart as breast. So it's responsibility of the radiation oncologists, and it's always a good practice to contour by someone and then have a check system. Other person just very quickly checks that yes, all the organs and all the structures are in place properly. So that might just take 2 minutes to just check whether all the structures are correctly drawn, whether breast is breast, whether heart is heart, whether left is left or right is right. That takes hardly 1 minute to 2 minutes time, but that makes a significant difference. And this is a very common practice in my department, while one person contours, and before it goes for the dosimetry or planning, other person mandatorily verifies that all structures are correctly drawn. And sometimes even I also do that. Some junior might be contouring, I verify, and even if before it goes to planner, I check whether all the structures are correctly drawn or not. So this is a very nice analogy which I gave, that you might have a very fine racing car, but if you do not have the brake, if you do not have the seatbelt in place properly, it might go wrong. Similarly, the OARs are like that seatbelt and brake in radiation oncology, which should show you that, okay, you need to stop here. So one should not forget to read, and what to read. You have very nice textbooks, you have fantastic guidelines nowadays coming from across the world. There are American guidelines, there are European guidelines, there are Indian guidelines also, and there are Chinese guidelines. So which guidelines should you follow? You have to customize and you have to fix that, okay, I want to follow this American guideline or I want to follow the European guideline. Occasionally you might need to combine both of them together, but that requires a lot of understanding, and it might vary from one patient to another patient. For the junior colleagues, what I followed always, that when I was in my learning phase in early part of my career, I used to go to the department before anyone reaches the department. I used to grab the system and I used to mock practice. And that actually helped a lot, because even before my senior checked, I have contoured it and I have verified whether the corrections he made and what is the difference between the corrected contouring and what was my contouring. So that always gives a lot of understanding. You must compare your contouring with your senior or the or whoever is in charge when they corrects it. That note the changes, whether your contouring has is significantly different or not. So what I used to do, I used to give an initial to my contours, like I contoured breast, so I like breast left underscore DM, that's my initial. So everyone understands that this contour has been done by this person, and when the physicist or the dosimetrist plans, they will understand whether that structure needs to be prioritized or can be ignored. So it has to be decided as a departmental policy that the structure with this initial are actually meant for planning, and others are either for test or for learning purpose. And yes, whoever is teaching you, always give them a good treat, because a satisfied stomach gives you always better outcome. So while we contour breast, I always give a significant importance and time to contour the skin properly, and it's not about contouring the body, which is always system generated, but I create a different strip of skin, sometimes a 3 mm or 5 mm. So that's what I did as part of my research protocol, and I prefer creating a 5 mm thick soft tissue under the body as a skin, which is around 2 to 3 centimeter around the breast, and that will be like a sheet of skin around the breast. So once you contour, this is a big time consuming process, but if you can do this, then you can avoid any unnecessary hotspot in that area. Always use a soft tissue window while you are contouring this body and skin. Always make sure that the body contoured by the auto segmentation tool is actually taking care of the entire skin and the nipple areola complex. Many a times the body contoured by the system may not be correct, and you can miss, or there can be some unnecessary hotspot situated over the nipple areola complex, because many a times the body does not take care or does not include that nipple. There are also some differences where the structure changes all of a sudden, so be very, very careful that you must check the body and skin before you start contouring, because many of our maneuvers actually are dependent on the contour of the body. Like when we trim the CTV or PTV by 5 mm, so we do it from the body, and if the body is not contoured properly, you may exclude, or you may actually trim a larger part of the breast or lesser part of the breast. So in both the cases it will be wrong. It's very important to know the auto segmentation tool and always check the contours done by the auto segmentation tool. And even with the latest version of the softwares like Eclipse, I have seen that many a time the spinal cords contoured by the auto segmentation is not correct, and it required manual editing. So it is very important. Always use a proper window width and window level. Contour all the tubular structures and luminal structures 10 cm above and below of your PTV. This is the suggested window width and window level which you can use during contouring different structures. If needed, I can share this entire presentation with you, so it's not a problem. Once you do it on a regular basis, and then gradually you train your eyes after a certain time, you'll be able to adjust the window width and level without actually noting whether the HU values. So for all planning purposes, I use a slice thickness of 3 mm or less with an inter-slice gap not more than 1.5 mm. So for all routine breast cancer planning, 3 mm is good enough. Reconstruction of images at 3 mm or less. Whatever kind of diagnostic images or pre-treatment images you have, like CT, MR or PET, it's a good habit to fuse all of them in your planning software. And if you have a registration software, it's always good to have co-register all these images to have best information about the gross tumor, the primary, and the nodes together. Sometimes it gave us information about some missed metastatic tumor as well, like there was some small lung nodule which was missed, but when we fused it, we could identify, we went back, we discussed, and the inter-treatment protocol changed. So it's very important to have a look on the pre-treatment or pre-chemotherapy imaging. Before you start simulation, it's very important to clinically mark the breast, chest wall, scar, and the drain site. We always use a copper wire, and we usually avoid using lead wire, which gives more artifacts. We prefer using a breast board and armrest, and all our breast cancer patients are mandatorily simulated with IV contrast to have a better understanding of the vessels and some nodes which we can occasionally identify in the IMN or SCF region or even dissected axillary bed. It's good to have DIBH facility if you are willing to have good result in terms of cardiac toxicity. So these are the gadgets we have for DIBH, and any center who is planning or who has DIBH facility should have these type of gadgets, like you have monitor for patient tracking, breathing tracking, you have a breath tracking device, and then you fix an amplitude. So at our center we fix the amplitude between 2.5 to 3 centimeter. And once the patient is achieving that amplitude, we scan the patient, and that's how in real life the patient or the setup looks like. We use a very limited body mold to fix the chin and the upper part of the chest. We do not cover the breast with mold, so that the purpose is so that the chest wall can expand maximally. So anything put over this part will reduce the chest wall movement, and that will nullify the main purpose of DIBH. And this is in short how the DIBH is practiced in my center. We train all our patients for at least 2 to 3 days to train them the specific breathing pattern which they should follow during simulation and the treatment. And we fix the amplitude, as I mentioned, that it's fixed for at 2.5 to 3 centimeter. And our cast for immobilization includes only the chin and upper part of the chest. The breath hold coaching is also done with a cast over the patient. There is a monitor which is available inside the room for the patient, where they can actually look at the amplitude, and they can guide, and they can train themselves, and they can also follow this during treatment. During treatment and during simulation, the instructions are given from outside, and the patient, once well trained, they can follow that instruction. A planning scan is acquired at a predetermined amplitude that is reproducible and which is comfortable for the patient, and the same setup should be reproduced on every day and with mandatorily imaging. Anyone with a less than 1 centimeter amplitude at our center, we think the patient is not qualified for DIBH, because the purpose of doing DIBH is not achieved when the amplitude is less than 1 centimeter. We do not get that amount of benefit. Now, what do we need to delineate? So let me start with the OARs. There are some OARs which are vital and which must be controlled for every patient, like skin, nipple, individual lungs, and then bilateral lungs as a whole structure. The opposite breast, heart, esophagus, spinal cord, thyroid, whoever is getting SCF or nodal radiation, and brachial plexus for nodal patients who are going to get axillary nodal radiation. And then good to have structures, the chest wall, larynx, carina, cardiac subunits, particularly for left-sided breast cancer, the cardiac vessels, mainly the LAD, head of humerus, for right-sided breast, the liver. Many centers, many people do not control liver for right-sided breast, but we have seen that the mean liver dose can be as high as 7 to 10 gray when unoptimized versus 1 to 2 gray when it is optimized. So there is a significant dose difference in liver for right-sided breast tumor, particularly when the patient is treated with IMRT or VMAT or ARC treatment or helical tomotherapy. For left-sided breast, we also contour the stomach, because we have also seen a lot of patients with significant dose of deposited to the stomach when they are not optimized. And DAR structures for patients who are going to get SCF and axillary radiation. Now, these are the targets which we contour: the GTV, which includes the pre-chemo GTV, the cavity and seroma, and the scar inside the breast, and also any visible node in the IMN or SCF region. And then we know what is CTV, the areas of microscopic spread, which includes the whole breast or the partial breast as per the indication, the entire chest wall, the scar and the drain site, and the nodal drainage site. Although not practiced for breast, but yes, the concept of ITV is there, so it takes into account all the movements, and then you create an ITV, but it's usually not done for the breast contouring. A PTV margin is given to take into account the setup inaccuracy and the motion, and additional block margin for the physics. Now, we started a protocol almost 13 years back for doing SIB in early breast cancer, and we have defined our how to contour the OARs, how to contour the targets. And then in 2020, we did a dosimetric study where we compared DIPH with proton versus DIPH with photon for left-sided breast cancer. And we have also defined here how to contour the cardiac chambers and the cardiac subunits. So the interested readers can connect me, and we will be very happy to share these articles. So the anatomic landmarks are very important when you contour the breast. So I have divided them into structures like muscle, vessels, bones, and cartilage. So these are the muscles: pectoralis major and minor, sternocleidomastoid, scalene group of muscles, latissimus dorsi, and subscapularis. So these muscles will have references when you are contouring the CTV. Vessels which are important are axillary vessels, subclavian vessel, internal carotid artery, internal mammary. Cardiac chambers, root of aorta when you are contouring LAD. Lateral thoracic artery as boundary for the breast glandular tissue. Medial mammary artery also serves as the guiding landmark for contouring the breast tissue. C5D1 when you are contouring brachial plexus. Sternum is guides to decide the medial border of the CTV for breast or chest wall. First rib to fourth rib, it helps us guiding the contouring of IMN, and coracoid process guides us in contouring level 3 axillary lymph node. Cricoid cartilage guides us about the upper border of SCF. So it's not possible to go into individual targets or these anatomical landmarks, but one must learn how to identify these structures. So few anatomical landmarks which I felt necessary is the lateral thoracic artery. And if you are unable to identify, or if there's sometimes it becomes difficult to differentiate between the fat of breast and the chest wall fat, and this can serve as a guide where your CTV will be limited medial to that. The medial mammary artery, where we can actually limit the medial part of the breast CTV. Anterior and medial scalene group of muscles, and this helps us in delineating the brachial plexus. So initial couple of scans, you might need to contour these anterior, medial, and posterior scalene group of muscles following the guidelines. But as you train your eyes, at certain point of time, you will be able to actually identify the nerve roots between these two muscles. It will be very easy for you then to identify and then contour directly the nerve roots rather than contouring the entire scalene group of muscles. But it requires a lot of training before you reach that stage. Pectoralis major, like a large sheet over the anterior chest wall, and it actually guides the posterior border of the CTV. Pectoralis minor is very important for contouring level 2 and level 3, so this works as the landmark, the medial border, lateral border, to delineate the level 2 and then level 3, which starts at the medial edge of this pectoralis minor. Latissimus dorsi, it again helps in restricting the level 1 group of lymph node. Then sternocleidomastoid is very helpful for contouring the SCF. And of course the axillary vessels, because based on the anatomy of axillary vessels, you are going to define level 1, level 2, and level 3. So because of shortage of time, I am not going into the details of this, but I am sharing 2 links of my lectures where I have described in detail how to identify the vessels and then nodal delineation. You can actually get this on YouTube, and I have tried to make it as lucid as possible for the radiation oncologists. Now, the clinical scenarios I have grouped the 1, 2, and 3. That means the breast cavity together, whole breast, sequential, and integrated boost. Now I have clubbed them together because the target remains same whether you are going ahead with sequential boost or you are going ahead with the integrated boost. So that does not change. So our primary target is breast, and we include the total glandular breast tissue. So the dorsal aspect of this is the ventral aspect of pectoralis major, or the posterior side of the ribs and intercostal muscles where there is a deficiency of the pectoralis muscle. The ventral border is 5 mm under the skin, and when we talk about skin, it's not actually the skin, it's actually the auto-contoured body. That is why I said that is very important to check each and every section whether the body auto-contoured body is actually correct or not. Now this is mostly important for T4B, C and T4D, where we will extend our CTV to include the entire skin, and we will avoid any kind of underdosing over the skin. A bolus may be required depending on planning software and treatment machine, because in our center we are equipped with variant age and tomotherapy both, and when we plan with helical tomotherapy, we usually do not require a bolus. Tomotherapy can actually augment the dose over the skin. It has a very good capacity to give adequate skin coverage. So for patients who are being treated with tomotherapy, we do not make or we do not place any bolus. However, for centers where tomotherapy is not available and skin dose is required, it's required to create a 5 mm bolus over your intended area. The cranial border is the inferior aspect of sternoclavicular joint. The caudal border can be adjusted depending on the inferior extent of the normal breast, and sometimes we might get confused because of the merging of breast fat and the chest wall fat. So you can follow the clinical breast marking with a copper wire, which we discussed at the beginning. Also, presence of a breast radiologist to understand how glandular tissue looks like and how the inherent fat of breast looks different from the subcutaneous fat. There is a difference between the appearance of breast fat and subcutaneous fat, but of course it's a radiologist's job to understand. You can take their help. And we are very proud to say that whenever we are in confusion, we always call our radiology colleague to show us and guide us for contouring. And it's also very important to have a dedicated breast radiologist who can also guide you for contouring the seroma or the cavity. Now, many a times we contour the breast almost after 4 months from the day of surgery when the patient finishes adjuvant chemo. And then many patients come with different type of oncoplastic surgery. So it becomes difficult to identify the cavity or the preoperative breast tissue. So a radiologist will definitely be of great help in this situation. The medial border of the CTV will be ipsilateral edge of the sternal bone. That is why I said that you should understand what is the medial border of the sternal bone. And when you are in confusion, the medial mammary artery, which I showed here, it can guide you. So our CTV will be lateral to this medial mammary artery, and whenever required, medial to lateral thoracic artery, as I showed you. So lateral border is defined by breast tissue or lateral thoracic artery. Now here I am showing you the lumpectomy GTV. So you can see this red line, and then so what we do, we initially contour the entire breast as the breast CTV, and then we create the lumpectomy CTV to have easy maneuvering and saving our time. Now, depending, so we give 1 to 1.5 centimeter margin to the lumpectomy cavity and the scar tissue and the clips which are placed during the surgery, and then we edit it off from the pectoralis and 5 mm from the skin for early breast cancer. For T4, B, C and D, we do not edit it off from the skin. So our dose actually reaches the skin. And that is how we contour the entire breast CTV. You can actually see here the fiducials and also the clinical breast marking by copper wire, and you can see that there is not much of artifacts when we use copper wire. Make sure that the CTV is edited off from the skin for early breast cancer by 5 mm, and usually we avoid sharp angles, because when you create a lot of sharp angles and irregular contours, it becomes difficult for the software to optimize. So make sure that you give a fine and smooth contouring after all these maneuverings. So in our center, we use 5 mm to 7 mm PTV depending on the movement, and we edit of the PTV from the skin by 5 mm, and then we create that PTV eval as a structure where we optimize the dose. Now, what do we do when we treat with post-mastectomy radiation? So here the breast is not there and our target is the remaining residual chest wall. So again, the dorsal border remains at the ventral aspect of pectoralis major or the exterior side of the rib, similar like in whole breast. For T4A and T4C, that means when the skin is involved or the chest wall is involved, we include the entire chest wall. We exclude the ribs, but we include the pectoralis muscles whenever it is T4A or T4C, and also in case of T4D, we include the entire skin. For very thin chest wall, we have to extend this CTV to the skin, because whenever you edit it off by 5 mm, many a times it actually spares the chest wall to be treated. So be sure that the chest wall is not very thin, and that editing off by 5 mm from the skin is not excluding the actual CTV from the contouring. So the cranial border remains the same. The caudal border can be adjusted, and it's guided by the contralateral breast, extending your CTV by 1 to 2 cm from the contralateral breast's inferior border. Again, the medial and lateral border remain the same. In certain scenarios, you will find a large scar extending and crossing the midline. We never cross, we never chase the scar, but we limit the medial border at lateral edge of sternum. Now, you can see here how we contoured in this patient. The ribs are excluded, and there was a 5 mm editing off from the skin. We also mark the scar, but make sure that you are using actually a proper window to identify this. Now, this is how the guidelines show the scar. However, what I feel that we should actually include the tissue under the wire rather than the wire itself to be marked as the scar tissue. But this is mere the wire being placed over the skin. So the next scenario, APBI, as Dr. Rajesh was discussing the de-escalation strategies, there will be certain group of patients who are fit for small volume radiation rather than treating the entire volume of the breast or breast. So you can use any technique like 3D CRT or IMRT or VMAT, and the centers who have proton, they can also use proton. The dose recommended is 3.85 gray twice daily, at least 6 hours apart over 10 fractions, which should be completed by 5 to 10 days. The contour the GTV as seroma, which is the fluid and or the scar tissue, you can see here. Also contour all the surgical clips, give a 15 mm margin to create the CTV, and a 5 mm margin to create the PTV. Now, again, you have to edit the CTV and PTV from the skin by 5 mm. It's very, very important to have a daily imaging system to ensure that the treatment is directed to the correct place. Because this is such a precise treatment that even if the treatment is going wrong by 5 mm, there will be a higher risk of recurrence. You can plan by different techniques, like you can plan with 3D CRT. However, with 3D CRT, you can get a little bit larger spill. Using IMRT or VMAT reduces the spill, and you can have a very tight plan. And in our center, we usually treat all patients with VMAT. We rarely use tangent or helical tomotherapy. Now, in certain scenarios, our observation is helical tomotherapy is better than using VMAT or Epidarc, like when you are treating IMN and you do not have a DIB facility and you do not have proton. In that case, we have seen that tomotherapy gives better cardiac sparing than VMAT. So we did a dosimetric study, the same patient being planned with VMAT using Eclipse, and we planned with tomotherapy, and the dosimetric sparing of cardiac structures were better with tomotherapy. So these are the nodal regions we need to contour, like supraclav, axilla level 1 to 3, IMN, and posterior neck node. I will not discuss about the posterior neck node because in routine clinical practice we do not do that. So supraclav level 1 to 3 axilla and IMN, that is where I will focus more. Different guidelines are there, RTOG, ISTRO, and very recent, the RADCOM. You can decide any one of them, all of them are good, you can just follow any one of them. It's always good to follow any particular guideline so that you can generate your data, because that will maintain your, systematically that will be a better thing to compare. So the RADCOM guideline is very extensive, and basically it's to compare the proton with photon. So the structures contour, the CTVs are usually quite large. So as a routine, most of the nodal regions will get radiation under RADCOM, and that's a huge structure. And when you treat a left-sided breast, probably will be able to see the result in future that proton is better in sparing heart in such situation. So I usually start contouring from the lower part. So now you can actually ignore this chest wall or the breast contour. The yellow is level 1, blue is level 2, green is level 3, purple is IMN. And so why I start from level 1 caudal edge is gradually as I move up, it gives me easy understanding about where to start level 2 and 3, because the level 2 and 3 starts at the same level and ends also almost at the same level. So if we see the guideline, the caudal edge of the level 1 starts at a point where the pectoralis major inserts on the rib, and the cranial edge is at the level where the axillary vessels are at lateral edge of the pectoralis muscle. Now I am showing the lower edge, the caudal edge, and as I scroll, you can see how this level 1 is being contoured. So the rib or the chest wall medially and posteriorly, medially it is at the lateral edge of the pectoralis minor. Anteriorly it's latissimus dorsi and the line connecting latissimus dorsi and the deltoid. And of course, at the posterior end, you are limited by the subscapularis and the boundary of latissimus dorsi. Now, as you track this, you can see that the axillary vessel is exiting and the lateral border of the pectoralis minor. So this is the last end or the cranial most part of the level 1. Now again, I will go to starting of level 2 and 3. So if you see the guideline, the level 2 and 3, they start at a level where the axillary vessel is crossing the lateral border of the pectoralis muscle, and gradually you go up, you include the pectoralis minor muscle in level 2. So anteriorly it is, just imagine a situation, so posteriorly you will have the chest wall, the rib and the intercostal muscle, and anteriorly it is the pectoralis muscle. So that space is contoured as level 2. Now if I show you, that is how it looks like. So the pectoralis muscle, the posterior border of the pectoralis muscle, medially it is the medial border of the pectoralis minor, and laterally it is the lateral border of the pectoralis minor muscle, and posteriorly it's bounded by the ribs and intercostal muscle. So this is the space which contains level 2. So you start at the caudal edge and gradually you go up, including the same thing, and you finish at the level where the pectoralis minor muscle is being inserted to the coracoid process, tip of the coracoid process. So that is why it is important to understand where the tip of the coracoid process is, and that is why it is an important landmark for contouring breast. Now level 3 also ends at the same level, so we'll just show at the same level where we started contouring the level 2, level 3 also starts. Laterally it is the medial border of the level 2, anteriorly it is the same boundary of pectoralis major, posteriorly it is the chest wall. And you include this entire fat space, gradually go up, and you finish at the level where the pectoralis minor muscle is inserted at the tip of the coracoid process. Now, when we contour the IMN, so it's a tiny space which is between first rib and upper border of the fourth rib. So that means we have to start somewhere at the lower border of the head of the clavicle. That is where we get the first rib. And then we need to contour this space which is bounded by the clavicle, the pleural surface. So do not go inside the lung, but include this entire fat space. And you can actually identify this space after you contour couple of cases. So do not leave anything uncontoured in this fat space. And there is a relationship between how you contour SCF and IMN. So IMN starts almost at the lower border of the SCF. So as your SCF ends, the IMN starts. Now, where do we start SCF? So that is where the role of the cricoid cartilage comes in. So it's the lower border of the cricoid cartilage where we start contouring SCF. So medially, you contour from the medial border of the internal carotid artery. Anteriorly, it is bounded by the sternocleidomastoid muscle. Posteriorly, you contour till the posterior border or posterior boundary of the SCM muscle. Medially, you have to now identify the scalene group of muscles. So medially, it is bounded by the scalene group of muscles. That is why you also need to understand where the scalene group of muscles are. And as you go down, you need to include these subclavian vessels and contour till you are at the level of lower border of the head of clavicle, where the IMN group of lymph nodes will start. So, so I think we are almost at the end. The take-home messages are: contouring is very much vital for radiation oncologists. It's very important to understand the CT anatomy, and it's very important also to follow certain guidelines according to your departmental policy and which you feel feasible for your patients. Give due importance to organs at risk. It's very important to have a consistency in your contouring, which should be reproducible. So in case you are going to do some kind of research and you have various different approaches to contour, you will not be able to compare different doses between different structures. So in our center we have a fellowship program for interested people for all kinds of advanced and precision radiation oncology. You can reach out to me if you are interested. We have very new variant age and we also have a very good dedicated 64-slice CT scanner for our department, which is not shared with the radiologist, so it's only for our purpose. And we have 4D CT scan, DIBH, we have ExactTrack, and our OSNS is under installation. And we have HyperArc for stereotaxy. We also have second generation Tomo with Synchrony. I am deeply indebted to Dr. Atif Khan, Dr. Rahul Parikh for their imparting a lot of knowledge in me and instilling how to contour and a lot of practical aspects. I'm indebted to my colleagues, Dr. Brinda, Dr. Shobna, for their help in my clinical work and presentation. And of course, my patients, my teachers, and my family who always take the burden of my absence when I do all these activities. So with this, I'd like to thank all of you. And where we are ending here tomorrow, I'll be discussing the planning as the how to evaluate plan in hypofractionation era. So hopefully it will be interesting. Thank you so much.
Thank you, Dr. Dodul Mondal, for elaborated presentation on breast contouring. Now, I expect questions from our colleagues and students, residents who are sitting here. Is there any question? Please.
So they are my kids, my daughter and my son.
Thank you, sir, for the knowledge.
Typically, we use motion management for left side. We will have a larger part of the heart going to right side. So many times we are able to understand that before starting the simulation from the pre-op image. Sometimes if we see that the cardiac dose is going beyond our limit of tolerance and the major part of the heart is going to opposite side, we counsel the patient again regarding the need for the DIBH, and that is the kind of motion management we use for breast cancer patients. And I have shown you the flow of our DIBH protocol.
Thank you, sir. I have a question. How tomography can replace the bolus? And can you explain, please?
So it's a very difficult question for me to answer. I think a physicist will be in a better position to answer this question because I'm a clinician. So I see the dosimetry once my planner is giving me the plan. So somehow tomotherapy system, I do not know why, but this tomotherapy system has a potential to increase the dose at surface. So that might be because of the internal motion while the helical movement is happening, but that's the observation. So you can actually throw whatever amount of dose, you can even make it 100%. So that is why for patients who are being treated with tomotherapy and requires a skin dose, we do not add any bolus. That can be optimized by the system itself. But if you are interested, then you can definitely come to our center, and our physicist will be in a better position to understand these physics aspects.
Thank you, sir. Your presentation was very knowledgeable. During treatment, I noticed that a patient, after giving 10 fraction of radiation, suddenly develops seroma. At that stage, what we should do? If patient develops seroma after giving 10 fraction, there was no seroma when we start the treatment.
Yes, a very interesting question. Usually we do not encounter this problem during treatment because the adjuvant radiation is given a long time after the surgery has happened. But the patients who have received neoadjuvant chemotherapy, and then BCS, those are the typical patients where we usually treat within 4 to 5 weeks from the date of surgery. And in that group of patients, usually we see a seroma to begin with. But your question is very interesting. Probably I will do an ultrasound and we'll check whether the seroma was actually there before starting the treatment or whether it has appeared during the course of the treatment. I am not very sure whether aspirating at that moment will be a good idea, or probably I will do a rescan and re-optimize. If the seroma is very large, occasionally where it can happen, like the surgeon has done an axillary dissection and the seroma has developed in the region of axilla. So if I began with without seroma, a patient without any seroma who has developed a seroma at the level region of axilla, I'll simply send the patient to our IR department, interventional radiology, for aspiration and leaving the anatomy which was there before starting the radiation. But if it is developing within breast, then I will discuss with my surgeon about the reason why seroma has appeared in between treatment which should not have been there.
Thank you, sir.
Thank you, sir, for a nice presentation. So my question to you that you have shown during radiation, the patients use thermoplastic immobilization device in breast patients. So do you use this thermoplastic immobilization device in every case, and does it increases the skin toxicity?
No, so thermoplastic devices do not increase skin toxicity. We usually we have a departmental policy of using thermoplastic mold for all patients, and for left-sided patient I have shown you that during the DIB is the kind of mold we use. Otherwise, it's a routine thermoplastic mold for right-sided patients, and we have not observed any additional skin toxicity because of the mold.
Thank you. Presentation. My question is, sir, you showed that you draw the wire separately over the scar. The wire you put over the scar, you draw it separately. Do you see the dose over the scar separately also?
Yes.
What is the purpose? I want to know.
Hello. Yeah. So see, there is a difference between wire and the scar. So when you are contouring, you should not, and you are willing to treat the scar. Like advanced tumor, where you actually willing to throw the entire dose till the skin surface. You need to conclude that. What happens when you contour the wire as a start, you actually throw the dose or you deliver the dose beyond the skin. Because if you just think logically, you put the wire over the skin, right? So if you conclude that as a structure, and if you want to include that structure within your CT band and PTV, then the dose is actually going beyond the skin, which is not required. Because our volume is under that wire. So you contour the wire, but you must adjust your window width and level properly so that this contouring is correct. That is why you have to start with a soft tissue mode so that you can check whether the skin or the body is covering the entire soft tissue or not. So ideally, your body, the line of the body which you are contouring should be just underneath the copper or lead wire. So we routinely use copper wire to reduce artifacts. There are centers who use lead wire, which is a little bit thicker than the copper wire, and it also causes a lot of artifacts, so it becomes difficult. So if you control both, then you will be in a better situation to understand what is going wrong or whether everything is correct.
Thank you.
Thanks a lot. That was an excellent presentation. I'm Dr. Bhaskar Chakraborty, consultant radiation oncologist. So I have one question that's from my day-to-day practice. Sometimes we see some patients with dilated cardiomyopathy with thin chest wall. So at that time, what is your planning strategy? So whether you will go for the URTC plan, whether you will go for the RTOG plan, what about your strategy? And what importance do you give? Do you give the proper dose to the ventricle or dose to the vessels, things like that?
So if I understand the question correctly, are you talking about early breast cancer requiring whole breast radiation or post-mastectomy radiation?
Post-mastectomy. Thin chest wall, dilated cardiomyopathy,
so
yeah.
That's a very tricky situation, and if it is on the left side, then of course we'll go mandatorily for DIBH. And if our DIBH protocol is unable to achieve the dose, we must give the patient the option for proton beam therapy if the patient can afford. Also, at this moment, you should loop in your cardiologist to treat the cardiomyopathy and find out why. If it is chemotherapy induced or whether it is pre-existing, although that will not change your radiation plan. But still, you might have a treatable condition where if it is a reversible cardiomyopathy, you can treat that. If it is irreversible, then you have to be even more cautious to treat it properly and sparing the heart as much as you can. If there is indication for radiation, one also needs to judge between the potential danger of omitting radiation and the ongoing cardiomyopathy. Which one is going to kill the patient earlier? One need to judge between these two options. But of course, one should definitely utilize all the technological advances available. If your center is having robust DIBH program and you can spare the heart, you are safe.
Considering the planning process, do you have any experiences with the hybrid plan versus VMAT or TOMO? So which one is better?
No, so we do not do hybrid between VMAT or TOMO. If we decide to begin with, if required, we create plan in both the systems. So if required, I'll create one plan with VMAT and the other plan with TOMO, and I'll compare which plan is better. So whichever plan is better, we'll go ahead with that. As of now, we have never treated any patient with a combination of VMAT or TOMO, but interesting idea.
Not VMAT and TOMO. I'm telling about the hybrid.
So definitely once I'm back, I'll create one such plan using a hybrid model and see what happens.
Okay.
So one practical approach, like sometimes we run after the coverage, like we have to achieve 95% coverage. Now for breast, many a times we do not need the 95% coverage. Even an 80% or 85% coverage probably will be good enough. So I also look at post-mastectomy patient. If it is a post-mastectomy patient, I'll look at where was the pre-chemotherapy or pre-treatment GTV, whether it is at the medial quadrant, whether it was closer to heart. Because if you see, the highest risk of recurrence is in and around the initial tumor. So if the initial tumor was away from the heart, I will not be probably bothered that much to give a very high coverage near the heart. I will rather accept a cold coverage to spare the heart. and I'll be giving that much benefit of doubt, or I'll accept that much risk of a recurrence.
Radiation planning is a very demanding technical and logistical procedure. What help do you see us receiving from artificial intelligence in terms of optimizing the process?
Very thought-provoking question. We do not use artificial intelligence as of now in our planning. It's everything planner dependent and manual dependent. For contouring part, we initially tried to explore the auto contour options available with our softwares, but we are not happy. Like I shared at the beginning that so I started contouring the spinal cord. It's a very basic structure with Eclipse, and I was not happy. At many sections, the spinal cord was not contoured properly. So as of now, I do not use auto contouring, and the entire planning is manual, user dependent. So I think it's a very AI is definitely coming in a big way. So you can like there are options of planning library or contouring library, because that requires a lot of efforts. Each and every patient to be contoured, checked, rechecked, and then fed into the system. So that gives you an idea, and you can incorporate that data as in your system. Or a purely AI driven, which already has taken into account the pre-existing images. So probably this entire AI driven approach is better than the library. And but to be honest, we do not use AI as of now.
I have only one question to my friend or colleague, whatever that. ISTO guideline, Radiology guideline, RADCOM guideline. The three guidelines are popular now. After doing this planning and evaluation of the recurrence, different site of recurrence, whether there is covering of Radiology guideline or ISTO guideline, both guidelines there are some faults or there are some missing, that is geometrical miss, and that has been corrected in the RADCOM. Recommendation is that for the early breast cancer, ISTO guideline is very good. For the locally advanced, Radiology is good. Can you explain this?
So since 2017, I have been following RADCOM, and I usually follow RADCOM, and I have been following RADCOM for almost last 8 years now. And I will not be able to answer this question, but what my understanding is, nothing will be 100% complete in that sense, but I found RADCOM as a more comprehensive, which includes or which actually taken into account all the previous guidelines proposed. So that is why I try to follow the RADCOM guidelines, but the indication might differ. So I may not be treating the posterior axillary nodes. But if I contour level 1, 2, or 3, then I will be following the RADCOM guidelines and treat this.
Okay.